Well, first of all, thank you so much for having me. I'm delighted to be here on behalf of the WA Psycho-Oncology Service. I am fairly new to the WA Psycho-Oncology Service in that I've been there about 6 months. I have a background though in hospital social work at Royal Perth. So I've worked in oncology for a number of years and I'm absolutely delighted to be one of the first times I've had the opportunity to present to GPs. So I've put together this presentation with very much that in mind and trying to give you a sense of what commonly psychosocial distress looks like and where to kind of go with that, using the resources that are available to you, along with the psycho-oncology model of care. Okay, so for those of you that aren't familiar with the Western Australian Psycho-Oncology Service, we're a statewide specialist clinical psychology service specialising in psychological assessment and intervention. We're a 4-year-old service and we're located in Shenton Park. That's where the hub is in our outpatient clinic. We do, however, do some in-reach to Royal Perth Hospital, Charlie Gardner's and Fremantle. And we're quite a small team, there's 8 clinical psychologists, which is a combination of part-time and full-time clinical psychologists. The way in which WAPOS was set up was to kind of move in the direction of providing, I guess, a future where routine interdisciplinary oncology care met the needs of your spiritual, your social, all the elements of psychosocial care, along with your physical needs, along with your psychological needs. Generally, a lot of people that work in oncology don't really know about the model of care, and it really sets, I guess, the expectations and the standards for being able to provide good psychosocial care. It's kind of like a pyramid almost approach, whereby everyone that enters that's been given a diagnosis of cancer has some level of universal care, and that involves some education, a baseline psychosocial assessment, general information and I guess where to go to next, referrals on to their oncologist or whoever it may be. And that's what everyone should get, and most people do. And then there's a certain percentage that might need extra follow-up in terms of meeting their psychosocial needs. So that might be through a cancer nurse coordinator or a social worker, and generally it goes up the pyramid. So then there's another group that have gone and met with a social worker or a cancer nurse coordinator, and their needs also, they've got additional needs on top of that, and they'll then seek out psychological help. We can report up to 66% of people with a cancer experience will also suffer from long-term distress. And some of that is 30% or more will suffer from an anxiety disorder, and depression rates are between 20 to 35%. So the guess, we don't really want to underestimate the power of that universal care. So that's the kind of the point of entry, and that's generally where I see a lot of GPs playing a crucial role, is providing that universal care. And because ultimately, if we can provide good universal care, it kind of prevents them moving up through that pyramid. So if you can give them accurate information and you can offer that baseline psychosocial assessment, then their needs can often be met from day dot. But I understand that can be really difficult to do, particularly if you've got some really anxious clients already. I guess part of the challenge that I often see for GPs is that you kind of get lost along the correspondence of someone's continuum. And often I have I only had a GP last week who said to me that they didn't know that their patient had been given a palliative diagnosis and that they were being treated palliatively. And so that came as that the patient didn't even know it, in fact, but had been referred back to the GP, and the GP had to actually inform them that suddenly this was the case. So there is, I think that is a challenge that a number of GPs are experiencing, and it is well documented in the model of care as well. I think the point that the model of care really makes about GPs and why you're well placed is that you have an extensive knowledge of a patient's background and their family circumstances and their social history and any comorbid physical or mental health issues. So in that way, you provide almost, in a sense, a better psychosocial assessment than probably anyone in the entire cancer journey, because you have that continuity that no one else can really provide. The risk factors I just wanted to quickly skip over. Just because the patient may have one or more of these factors doesn't mean that they are necessarily distressed or need a referral on immediately. But this is just to say that research shows that these factors increase the risk of getting distressed. In terms of assessing distress, I tend to break down really simply. You've got to ask the questions, validate the response, and also you can almost validate in asking the question, normalise and actively listen. Now I'm sure these are things that you've already been well trained in doing and you're probably already doing, but men typically won't express their distress without asking a really good question. So I put a couple up there, and they are there things in your life that complicate how you deal with cancer? Or some men have concerns that related to sexual function after treatment or surgery. Is this a concern for you? Generally, we need to be quite direct, and even when I see gentlemen that come into our clinic or in a hospital setting or wherever, you have to be quite open and honest for them to feel comfortable and safe to express their concerns. If it's difficult to ask some of these questions or you need a little bit of an intro, the distress thermometer is used widely by a number of cancer nurses in the state and across the country. And basically it's one way of assessing psychosocial distress. Generally on the scale on the left, a score of 7 or above suggests clinically significant distress, which would then need a referral onwards. The boxes are, I guess, a really good way of generating some of that referral and generating what their concerns are. That distress thermometer is available in the model of care. I wanted to give you an idea of what clinically significant distress is. And generally speaking, clinically significant distress is any kind of multifactorial or unpleasant emotional experience of psychological, social and spiritual nature that is problematic or burdensome, interfering with treatment or coping with cancer, detrimental to quality of life. Less adaptive coping styles that are quite inflexible and self-defeating, and that's generally where we kind of come involved. Who to go to for what? This is again just a bit of a general understanding of who you might be referring onwards for different concerns, particularly psychosocial concerns. This is also in the model of care a good way of knowing who does what. And then some useful resources. So the ones that I really wanted to give you were up here. The Cancer Nurse Coordination Service I rely on very heavily. They become quite a linchpin in someone's ongoing quality of care and measuring psychosocial distress. They're a great one to coordinate appointments and make sure that referrals are actually followed up on, and generally can be quite a close source of support outside of the family. The Cancer Council, there's 2 books that I would definitely recommend that a lot of my patients find benefit from reading, is the Coping with Cancer booklet and Life After Cancer, and along with for carers and family members caring for someone with cancer. There's some really key ones in there that really go through a lot of the common experiences and the common problems people are facing when they're on the cancer journey. Solaris Care, there are some specifically male programs that are run every once in a while out of Solaris Care, and that's for complementary therapies, so massage and Reiki, and they also offer some counselling, and that's located at all the major hospitals. And of course the Prostate Cancer Foundation, it's an online resource that runs some events every once in a while. But they also, on that website, they have some wonderful personal stories that I know that some men, when they've been given a diagnosis of prostate cancer, really look to those. So thanks for having me, and give me a call if there are referrals that you'd like to send through.